Yes, thank you. I think thank you for this inviting me for this session, and I think this is a pertinent talk after Dr. Natarajan's talk on how to screen diabetic retinopathy, especially in the Indian scenario. So the main problem that was highlighted is that the type 2 diabetes is evolving and is really increasing in especially India being the heart of diabetes in the world. And you can see by 2030 we're going to have 101 million population who are type 2 diabetic, and it will go up every year. The national prevalence itself is 8.9% across the age group of 20 to 79 years. So 1 in every 11 adults is affected with type 2 diabetes in India, which is very alarming. And high proportion of these patients are underdiagnosed. They are not diagnosed at all. And among the diagnosed also, up to 50% of these patients have poorly controlled disease. The main worrisome problem and the problem that we need to solve in from the eye perspective is asymptomatic DR, because 90 to 95% of population who have diabetes, who have diabetic retinopathy, will not be aware of it because they will have no symptoms till it's sight threatening. So AIOS, VRSI, Queen Elizabeth Diamond Jubilee Trust and WHO have come out with various DR screening guidelines. But the key points on the guidelines would be there's a need for population level screening for diabetes and its complications, and an integrated approach is required for people with diabetes to minimize blindness due to the retinopathy. So there are factors in previous experiences which are for promoting success. Equitable and widespread access to laser treatment and trained staff is very important, because we want to basically have an end-to-end loop, so that we not just diagnose it but we treat it there itself. That's very important. Otherwise, this patient again will have to come for a re-evaluation and we'll lost to follow up. Initiation as local screening programs that can scale up, and screening offered at locations and times that meet the need of the patient. So maybe doing a day screening camp may sometimes be less effective than doing an evening camp, which may be more effective in that particular subset of population where the people are working. So it's very important that there should be a buy-in from the healthcare professionals, the patients, and their families. That's very, very important. It has to work as a team. And as has been shown previously by Dr. Rohit and Dr. Professor Praveen Vashisht, that accurate data collection, review, and reporting is very, very important for you to understand if you're going right or you're going wrong. There are challenges and barriers to screening, which is very important to understand, that because of the decentralized healthcare or many private insurance-based healthcare, they have low success. And eligible population of screening increases every year as the population increases. And majority of patients do not show up because they have no symptoms. And even though you tell them that you're diabetic, you need to come for an annual follow-up, still they don't come back because they have no problems. Less than 85% uptake in the annual eye examination invitations observed consistently in England and other parts of the world. So this basically tells you that though the patient is aware he has the problem, he may not come to you because he has no symptoms. So very important to have a way forward in diabetic retinopathy screening. Systematic tele-screening programs, as has been highlighted by the LVPI and the AIMS program, are cost effective, which can be done by a trained technician, not just an ophthalmologist, because you need to have people who are locals so that they can be volunteers and they can be part of your team who can take care of this at your base level, the rural area, the vision center, and the primary eye care level, because you need to have a very good and strong tele-ophthalmology bone, so that you're able to have very good screening, and this can be seen by the ophthalmologist at the tertiary or secondary level, and patient who requires treatment has to be referred as per the triage, and then they can be treated. So that, and a feedback loop is very important, so that you know the patient has gone there and has got treatment done. So using non-physician graders for initial screening at these areas is a very important part of the success in the way forward. And establishing your screening pathway is very critical. You should know the flow in which from the base level to the tertiary level, how the patient will be screened, followed up, and monitored. So not just treating them once, because diabetic retinopathy requires multiple laser therapy, sometimes it requires injections, it requires follow-up. So you have to have a proper monitoring course and follow-up course. So internal quality assurance and external quality control mechanisms are very important. The AIOS task force recommends at least 80% sensitivity, 95% specificity and less than 5% technical failure rates in such systems. So a whole team has to be certified and have to be involved. The involvement of ASHA, it has been nicely promoted now through AIMS with Professor Vashisht being there, that you getting ASHA, they're getting an incentive, because incentive is such a important, crucial aspect for them and for any worker, because they have to be rewarded for the work that they do. So it's very, very important that this should also be incorporated in diabetic screening. So every type 2 diabetic should be screened once a year, and that effort has to be made at the grassroots level with the help of the ASHA. That is the way you can actually track each and every person, because ASHA is the local person in the neighborhood who will inform the patient that he has to go for the follow-up. So key steps in DR screening would be identifying the eligible population, list everyone who has diagnosis of diabetes with the help of the endocrinologist in your neighborhood, as well as in the rural area. You need to make a holistic approach so that you can treat the patient as one. So guidelines, protocols, SOPs have already been discussed, but very important to have them to avoid any system failure. Follow-up surveillance is very, very crucial, and rescreening for screen negative patients should always be done. So important to have an important uptake. So not just screening, you have to also tell them how to prevent diabetes, which is the most important part, because prevention is better than cure. So knowledge, attitude and awareness and motivation of people at the grassroots level, how to avoid getting into the trap of not working and having type 2 diabetes is very, very important, because that will improve their overall the chances of us having less amount of DR in the coming years. Health education material, which has been very nicely shown with the help of the government flyers that we are available and templates that everybody uses, and very important to develop them in their own language, so that every part of the India can disseminate this information widely and properly. The patient should be informed that he will require this much time in the screening program in the vigilance center. He would require dilation and what can happen post dilation, so that patient understands that nothing wrong has happened to him post the dilation, so that it should not be an unpleasant experience which he should not land up not doing again. So very important to allocate the roles and responsibility of each person, each member of the team, so that everything is done properly and they do their work efficiently and properly. Public-private partnership, which has been spoken about before, is very, very crucial in such situations, because the government cannot be everywhere. So it requires private partners, it requires NGOs who are doing good work in that area, and collaborate with them so that the efficiency improves overall. And we have now good schemes available since the past few years. The PMJ Ayushman Bharat, which has provision which gives you a nominal amount of 8,000 rupees if you are NABH accredited for 3 sessions of laser. And unfortunately right now anti-VEGF injections are not included in PMJ program, but I think is very, very important, which should be the next step, that they should include that, because a lot of patients who require the treatment land up not doing it because of this main problem. Thank you very much.
Thank you, Dr. Vaibhav, for a lovely presentation.